Well, good afternoon. I'm Guillermo Umpierrez. I'm a professor of medicine and director of clinical research in the Diabetes and Metabolism Center at Emory University School of Medicine and the chief endocrinologist sections at Grady Health System. I'm very honored to be able to participate in the celebrating Dr. Richard and Diane Guthrie in this program. I will discuss with you the use of continuous glucose monitoring in the hospital setting, where we are, and how CGM can help us in the management of patients both in the intensive care unit and in non-ICU settings. Before I start, let me present to you potential conflict of interest. I'm the editor-in-chief of British Medical Journal Diabetes Research and Care, and Emory University has received funding from some of our investigator-initiated studies from Novo Nordisk, Descom, AstraZeneca. This money goes to the university, not to me. So I will start with a couple of slides on the epidemiology of diabetes in the hospital and discuss with you the traditional way that we have monitored and the limitations of self-monitor glucose levels in the hospital and how the CGM can help us. But also we'll discuss some of the limitations that we have, where we are, and what challenge we have in implementing this kind of technology in the hospital setting. So here to the left is the number of people with diabetes up to a couple of years ago by the CDC. As we know, we have passed the 30 million mark. And to the right is the inpatient diabetes. There are over 7 million hospital discharges with the primary diagnosis of diabetes. And 14 million emergency room visits come to the hospital with the diagnosis of diabetes. And not only is diabetes, but it's hyperglycemia, that's right. So hyperglycemia, elevated glucose levels is seen in somewhere around 32% of patients in the ICU, as shown here in the top panel, and in 32% of those that require finger stick for whatever reason have elevated blood glucose greater than 180 in the non-ICU setting. Some of you may say, well, 180 is not too bad. What about 200? Well, 1 out of 4 patients in the non-ICU setting and also in the ICU has a blood glucose greater than 200. So hyperglycemia is extremely common in the hospital. And hyperglycemia in patients with and without diabetes is associated with increased rate of hospital complications. Here you have with increasing levels of blood glucose going from 100 to 300. You have increased rate of complications or a composite of complications that included pneumonia, acute kidney injury, respiratory failure, acute MR, bacteremia, and death. And there is no threshold, but increasing levels of glucose in both ICU and non-ICU is associated with increased risk of complications. So how we determine and monitor blood glucose in the hospital? Well, we have done is capillary blood glucose, that's right. We do have venous blood, but it's not very good in the way that is painful and it's costly. So in the last 40 years, we have done finger sticks. And it's good in the way that it will assess at one particular time the blood glucose concentration and help us to confirm hypoglycemia or hyperglycemia. In the ICU, we usually do measure blood glucose every 1 or 2 hours. In the non-ICU, we do it before meals and at bedtime. So it's easy to use. It's widespread adoption. All the nurses know how to do it and tell you, and you can adjust therapy according to blood glucose levels. But what are the limitations? The main one is that we don't do it more than 2 or 3 or 4 times a day. As I mentioned to you before, the guidelines would suggest that you have to do it before meals and at bedtime. That means that there's long periods of time, especially at night, that we cannot measure blood glucose. And of course, that is a significant limitation to recognize hypoglycemia, which has been associated with increased rate of complications and even death. So how good they are? Well, it's very good. For example, here you have a list of 6 large ICU trials that shows the blood glucose concentration in intensive and conventional therapy. And here you have the rate of hypoglycemia in this trial less than 40 milligrams. And hypoglycemia in the ICU, while we use IV continuous insulin infusion, has been reported between 0 and 19% of patients. So in some series, up to 1 in 5 patients develop severe hypoglycemia. In the non-ICU, there are several trials as rapid medicine, surgery, DEAN, many of them. And what you see here in the bottom within the red square is that hypoglycemia less than 70 is reported somewhere around 12 to 29% of patients in the hospital. So hypoglycemia is very common. And this is doing finger sticks before meals and at bedtime. Who knows how often we see hypoglycemia if we will do more testing during the day and night. The other thing that the problem with the capillary blood glucose is that we don't recognize asymptomatic hypoglycemia. This is a paper we published a couple of years ago, in which we took a large number, 250 patients who developed hypoglycemia less than 70. Then we went to the bedside and we asked the patient about symptoms. If you have nervousness, sweating, tremors, all of these symptoms that we recognize hypoglycemia. And it was extremely interesting, the fact that asymptomatic hypoglycemia was present in 45% of patients in the hospital. And it was more common with increased age, over the age of 59. And look at over the age of 65, it's 4-fold increase the risk of asymptomatic hypoglycemia. The other was having male sex, and elderly males or older males are less likely to recognize. And this is patients in the hospital. And so if you look series of patients with type 1 diabetes, hypoglycemia is reported somewhere between 15 to 45% of patients. And the problem is that continuous glucose monitoring just gives you sporadic blood glucose levels and does not recognize hypoglycemia. To fill this blank, or this deficiency, we have been using continuous glucose monitoring. And I would like to present to you our experience during the last few years. Before that, let me just review with you. The CGM means they are invasive, they're intravascular, venous, arterial. They're minimally invasive. This is what we see on TVs everywhere. The patients use in the ambulatory setting is subcutaneous. And we also have non-invasive or transdermal. And the definition of CGM is that you measure blood glucose at least every 5 to 15 minutes, most of them every 1 minute. So you have to have at least every 15 minutes blood glucose to call it continuous glucose monitoring. In the ICU, there are several studies, over 35 trials or studies, some of them prospective, some of them retrospective. They have looked at the use of CGM in the hospital setting, in the ICU. And more or less what they all say is that they are very accurate if you look for venous blood or laboratory or by the gas analyzer, blood gas analyzer. And about 86% goes within the error grid A and B. That means they are very accurate to this, to correlate with the blood glucose by the laboratory. But the MRD with finger sticks varies significantly in the ICU. Here you have, for example, if you do the free Libre, the Libre Freestyle, this is with the first generation, it was about 30%. And this is what we call the mean absolute relative difference, MARD, that measures the accuracy. We want this to be less than 10%. And you see that with the Libre, with the Guardian, it's well over 10 to 15%, up to 30%. These are studies with subcutaneous. If you look at intravascular, so venous or arterial, the MARD is fairly good. It's about 10%, 5%, 14%. Unfortunately, in the ICU, we have not seen major impact of using CGM trying to improve outcome in the hospital setting. And in a systematic review, both RCTs and observational studies concluded that the use of subcutaneous CGM does not seem to improve glycemic control in ICU patients. So it helps, but because we have nurses, it's not a big deal so far, except I will discuss with you in a minute now with COVID. And there are several limitations. First, substance interference like acetaminophen, some of them have been resolved because now most of the meters do not have this interference with acetaminophen or ascorbic acid at regular doses. There is lack of evidence in the ICU, as I mentioned before, and the invasive intravascular carries the risk of thrombosis and even infections. Also, there's cost involved, and there is limited data that in addition to have good continuous measure of frequent blood glucose levels, it really doesn't help much in recognizing hypoglycemia because we do the blood glucose every hour. This is the only Opti scanner with the only FDA approved. Unfortunately, it's out the market now. And I don't think in the ICU, the use of CGM is for prime time these days. But as you know, most of the patients admitted to the hospital don't go to the ICU, they go to the non-ICU settings. And there are several studies from the last 10 years that have shown good correlations. Our group published some 2015 and 2020, a couple of studies that I will discuss with you. First, there is a very good correlation with the finger sticks, and here you have blood glucose measurement from the date of admission to daily days, in red the CGM, in green is point of care testing. And if I mentioned the error grid A and B, that's where you want to be with good accuracy. In these studies, using the iPro Medtronic was about 92%. Not great, but fair. But more importantly in this study, what we recognize is that there are many more episodes of hypoglycemia that you would recognize for CGM compared to point of care testing. And I've mentioned to you before, a lot of hypoglycemic events are asymptomatic. Of course, you would never test unless it happened to be before meals and at bedtime. Other investigators have confirmed this data, that you recognize many more hypoglycemic spell with CGM compared to blood glucose capillary blood test. And this is from midnight to 6 in the morning and throughout the day. And in addition to that, it recognized more hyperglycemic events. In a study we just published last month in Diabetes Care, we tested the accuracy of Freestyle Libre Flash CGM versus capillary blood glucose testing. And let me share some interesting findings. First, the point of care testing and CGM has very nice correlation. But CGM reads about 12 milligrams lower than point of care testing. And here to the right is the beauty of using CGM in the hospital, is recognizing hypoglycemia during the day, but more importantly, nocturnal hypoglycemia. So when we are in the hospital, we ask for glucose before meals and at bedtime. That means from 9, 10 p.m. until 6 in the morning, nobody checks your blood sugars. And there is a significant number of events that happen during the night. Even what we call prolonged hypoglycemia or blood glucose less than 70 for greater than 2 hours at the time. So that's the good things about CGM. In that study that I presented to you, the error grid analysis A and B, that's what you want to be, was excellent. And the MARD was about 14.8 during the day. The MARD is very good for glucose level within the normal or elevated blood glucose. But in this study, it's not very good when the blood glucose less than 70. So if you have a blood glucose less than 70, you must do a finger stick. These were studies with Libre. Now we have studies with Dexcom CGM. And what we reported, this is a paper coming in Diabetes Care soon, is the reported is that in zone A and B, that's where you want to be, is somewhere around 98.6%. This is data on 205 patients who were treated with insulin with type 2 diabetes, combining data from the University of Maryland and Emory University. The good thing that it works well, even in the first 24 hours, in the first 12 hours, a little higher MARD, but overall it's good. During the first 24 hours, the MARD, that's what you want to be, somewhere around 98% good concordance between point of care testing and CGM. And after the 24, it's even better, 98.6%. We also look at what happened the first few hours versus the second hours, what happened with different levels of glomerular filtration rate. And what you see in here is that the GFR doesn't affect. So even if you have a patient with acute kidney injury, the CGM works well. We look at respiratory diseases now with COVID and pneumonia, it works fairly well. But during the point of care testing, less than 70, not very good. So we still have to do finger sticks in most of these patients. So what about the deficient? If you do a CGM, as you know, you have your reader here, it transmits to a smartphone or the reader, but it doesn't go to the nurse's station. That's right. That's what you want to be. So during the last few years, we have developed a system that we call glucose telemetry system. Then from the reader goes to the smartphone and is transmitted to the nurse's station. So if the blood glucose less than 80, it beeps. So the nurses go to the bedside, prick the finger, and confirm the evidence of hypoglycemia. And here are two of my coordinators, but you don't see here, unfortunately, very well. But the same as the cardiology have the Holter, now we have a glucose telemetry system 24/7. We're looking at different places. Is the arm, the abdomen makes any difference? And the doctors get this information every day. Here you have the hospital glucose telemetry system. They give you the average blood glucose, low blood sugars, in target range that we shoot for 70 to 180, higher blood glucose. They give you also glycemic variabilities and the time that is used. Here you have a patient admitted the first day, coming down, second day, still going up, third day, you got under good control. And you can get this information to the nurse's stations or on your Palm Pilot or in your iPad. And using this glucose telemetry system, we just published this paper last month in Diabetes Care. Together with the University of Maryland, we saw that we can decrease the rate of hypoglycemic episodes, hypoglycemic events, and here to the right, the time below range or the time below 70. Sure, if you have a system that has an alarm that goes off every time the blood glucose is less than 85, well, you prevent hypoglycemia at less than 7. So this is what we call the glucose telemetry system. Of course, the COVID that we talk about this every day is not a single minute of the day on TV everywhere that we have about COVID. And the silver lining about this with respect to glucose monitoring is that we have changed significantly the implementations of continuous glucose monitoring in the hospital. So having PPEs problems or having blood glucose testing in the ICU every hour, it doesn't make any sense. That's right. There's no way that we're going to change all the clothing, and it's just too expensive and not realistic. So what we have done is have this remote CGM now. We still do point of care testing, but just every 6 hours. And we have glucometer or GlyTech in our unit. And we talk between the CGM and the glucometer. And here, for example, in patients in the unit, has the CGM giving you the blood glucose, the IVs are outside the room, and we can also not outside the room, but we transmit this information to the nurses' stations. And you can make changes of the titration of insulin without going into the room and minimizing the use of PPEs and exposure because the nurses just do point of care testing every 6 hours, and it works very well. And it works even in critical conditions. So here you have somebody with on the Glytech, and here receive high doses of dexamethasone. Sure, glucose goes up continuously. And unfortunately, this patient the following day had a cardiac arrest. And if the cardiac arrest happened, well, CGM stopped working. This patient was resuscitated. And what you're seeing here is that after a few hours, the glucose, the CGM started reading again. And here you have the patient the next day. So you can really diminish or limit the exposure with good accuracy in these people. It's not only us, but this is a paper that's been under review for Montefiore. Same like us, they put this outside the room, and we have several now publications on the use of CGM during COVID. And again, you have this continuous glucose monitoring. And one of the studies that we're doing is, can you adjust insulin in this way compared to point of care testing? Can we do the same work or not? So far, I've just told you the good news about continuous glucose monitoring. But we have significant challenges. So first, it's a new technology. It's not commonly used from primary care or hospitalists. Most of them are not familiar, so we need a lot of education. The older CGM needed to have calibration. So of course, now we have two devices that don't need calibration because they are factory calibrated devices, and you have the Libre, Abbott, and the Descom, the G6. We still have to interfere with some substances. And the other thing that I'm concerned is that would be information overload. That means you get glucose every hour, every 5 minutes, every 15 minutes. So you have to get good accuracy and show evidence that this CGM is here to stay. The other is the implementation of the system, the continuous glucose monitoring. Now we're working with a dashboard that we can transmit information from several patients to the nurses' stations in the dashboard. And this is now also, we're implementing this to go the information to the electronic medical records. I believe that CGM has really changed the way we manage patients, especially in non-ICU settings. The other challenge is that there's still discordance between point of care testing and fingerstick, and by fingersticks and CGMs. You may know that point of care testing is not very accurate, that's right? It changes up to 20% from reading to reading. And now here you have CGM. And there are circumstances in which here in black numbers are point of care testing by fingersticks. And in the green numbers are the values of point of care testing by CGM. And there are circumstances in which here, for example, the CGM says 77, but the point of care testing was 113. Or down here to the bottom, you see that here by point of care testing is 96, but CGM is 58. So that occurs in about 6 to 8% of the reading, this discordance or discrepancy. So who do you believe? So far, point of care testing is the standard of care. So we go by point of care testing. But the good thing is that if you have a blood glucose less than 85, we just have to go and do the fingersticks. In the ICU, we have other challenges. And this is a series of patients, of 15 patients that we're doing with an NIH-supported study by Dr. Pascal. Is that here you have a patient going to the OR, and the CGM where the patient, the electrocautery, or the patient goes to pump, and they also cool the body significantly. You see that it quit working, and in many patients it comes back, but in some others it does not. So here you have during surgery, you have this blank episode, but a group, about 50%, it comes back after surgery. But in some others, that's not. And you have to calibrate the device or change the device after surgery. I think that in this series of post-CABG patients, we still have a lot of work to do to be able to utilize the CGM on a continuous basis for all patients. If they're not surgery patients, it works. Let me move for the next 1 or 2 minutes to what is coming up and give you a summary of what I tried to tell you today. What is in the pipeline? We now have meters that instead of changing every 3, 7, 10 days, 14 days, they can be implanted, and now in the United States are approved to 90 days, in Europe up to 180 days. Can you implant one of these Eversense devices and you have patients walking around not needing to do finger stick but just once a day or once a month? And now there are several companies working on these implantable devices. It should be important to notice that in the hospital, you can do CT or X-rays, but you cannot do MRIs in these patients. And we started working in closed loop system. And we have our own trial now using closed loop. The European have already shown that in a small number of people, you can improve glycemic control even better than using point of care testing and adjusting insulin therapy. Here you have an overnight period, you recognize hypoglycemia and you decrease the rate of hypoglycemia in our patients using closed loop system. So I think that this is an interesting procedure. So far, it's kind of complicated, but now we have closed loop system, that's right, that we are using in the ambulatory care. So now we're implementing and exporting this to the hospital care to see if using CGM with a closed loop, we can improve glycemic control, especially in COVID patients or in patients that we want to minimize exposure and utilization of PPEs. So in summary, CGM give you glucose 24/7, and you can have trace how the blood glucose goes. You can have alarms. Definitively give you a better understanding how glucose are going ups and down with trends and errors that you don't see this when you do point of care testing. The question is, can you improve glycemic control? This test has been going on right now. In a recent publication, as I mentioned to you, we have shown that you can decrease or reduce the number of exposure and more importantly, to prevent hypoglycemic events. But there's still much work to be done. We need to have FDA approved CGM. Now we're working with the FDA to correlate, not with point of care testing that is inaccurate, the finger sticks, but using YSIs or laboratory values to correlate well the CGM devices with these blood glucose with YSI. We need to implement a tremendous education and training program of our nursing staff, hospitalists, primary care physicians, for them to feel comfortable that that's the way that we want them to follow in the hospital. And of course, we need to simplify transmission. It doesn't matter if you know what the blood glucose is at the bedside. We want it to be at the nurse's station. We need to do pharmacoeconomic analysis. These studies are currently being done. Do you save money or you spend more money in this world that we want to save, improve glycemic control, but we want to spend more money? And of course, we need to make sure that I told you before, we have to have accurate system or a closed loop in the future to make sure that the insulin administration devices or protocol correlate with CGM. And this is now a reality. Again, I just feel very grateful for the opportunity to present this data to you and celebrate in memory of Richard and Diane Guthrie. Thank you very much.